Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. All right, let's talk about IO-TKIs. So obviously the other option, and it sounds like 80+ % of our patients, and I think probably in the US, is an IO-TKI doublet. There are 3, axi-pembro, cabo-nivo, and len-pembro, that have shown a survival advantage. 2 others showed PFS, but not OS. We won't really talk about those. Let's go in reverse. Moshe, I'll start with you. Tell us, let's take ipi-nivo off the table. You're going to give this patient an IO-TKI. How are you choosing which one? Are you kind of always using the same one? Do you vary based on X, Y, and Z?
Yeah, I mean, I put my patients into 2 camps within the IO-TKI regimens. And it's either an axi-pembro patient or a cabo-nivo/len-pem patient.
Okay.
Meaning I find that axi-pem is easier to tolerate for a patient who's older, might have more comorbidities, where I want to try that doublet, but I'm also comfortable dropping the TKI and knowing that the toxicities with axitinib short half-life will resolve relatively quickly.
And that's just an eyeball test.
There's no fancy test for it. I tell my patients that in 2023, still the best test we have is the eyeball test. There's no MRI that's going to help with that. And then the cabo-nivo and lenvatinib pembrolizumab, I find them a little bit more tougher for patients to handle. And I really don't think that the toxicities that are seen in the clinical trial setting are necessarily reflected in clinical practice. I find sometimes that we see these numbers and high rates of grade 3 or 4 toxicity, but actually in clinical practice, patients can tolerate these medications a little bit better than in the trial setting.
Okay.
And then within those 2, I generally will favor lenvatinib and pembrolizumab. No, it's not kosher, as we say, to compare them head to head, but when you look at the numbers, I think if you had taken a group of RCC experts 5 years ago and asked them what they would need to see from a trial to at least make that a preferable regimen, they would say, CR rates 15 to 20%, PFS close to 2 years, response rates over 70%. And those were the numbers that we saw. So again, it can be a little bit harder to tolerate for some patients because the lenvatinib is at a higher dose, which I'm sure we'll get to. But I do think in some ways it set itself apart with those numbers. So I will lean primarily on that for the patient who's young, healthy.
So who are you giving cabo-nivo to then? Anybody? Or?
I generally give much more of the len-pem. I give cabo-nivo probably more in the non-clear cell setting. So if I have a patient with papillary RCC.
Okay, that's fair. And we can touch maybe on non-clear cell at the end. But Shuchi, what do you think? How do you decide among the 3?
So, I mean, I have to agree with everything that Moshe said. Basically, there's no head-to-head data to compare these regimens. I was taught as a fellow, pick one regimen and get comfortable using it. So as it happens, I've gotten really comfortable using the cabo-nivo drugs. And to me, I've seen with the 40 milligram dose, especially if you're using it upfront, I'm not struggling a lot with toxicities. Of course, any patient who you start on TKI, even if it's 5 milligrams of axitinib, you're going to have some toxicities. But in my practice, I'm seeing that this combination is really well tolerated. I've struggled a little bit with lenvatinib, even when we were using it with everolimus in the second line, third line or advanced setting. So I tend to prefer the nivo cabo data. Obviously, we've seen higher response rates with the lenvatinib, but then there was about more than 30% patients who had to stop that drug because of grade 3 or above toxicities, and those rates were lower with the other IO-TKIs, and that's what I've seen in my practice too. So I've picked my choice. I'm using a lot of cabo-nivo just because I'm comfortable managing the toxicities related to the combination. I'm comfortable with the data, and so that's just been my practice.
Very reasonable.
Yeah.
Monty, I think I might know what your answer is going to be,
So
but
I'm glad you're sitting down because this is going to be shocking. You know, I tend to mirror sort of Shuchi's practice with cabo-nivo in the bulk of my patients. You know, I think the dosing strategy to me, you know, was a shocker when they announced the Checkmate 9ER study going from 60 milligrams in the salvage setting down to 40 up front. I thought it was a big risk, but I think it's a risk that paid off in a big way. You know, I found the 40 milligram dose to be a lot more tolerable, you know, and especially applied in the frontline setting when you juxtapose that strategy against len. We've tried with len, right? We've done the dose finding studies with it, haven't seen that, you know, dose adjustments really lend themselves to significantly reducing toxicity. You know, I do find that with cabo, we get away with, you know, the same, you know, ultimately overall survival advantage with probably less duress for the patient.
yeah, and I think we didn't talk about it, but all the OS hazard ratios are almost identical, which is really surprising almost.
Yeah.
I mean, they're all 0.7, 0.70, 0.71. So I tend to be an IO-TKI user. The len-pembro data to me is convincing. Like you say, we shouldn't compare, but we have to compare, right, when we're selecting for patients. I think len-20 is very difficult. I do start at that. When I talk to other oncologists sort of in the community, nobody starts at 20. Nobody.
You know, and that really worries me, Brian, because I feel like when folks are starting at len 10, len 14, which is what I'm seeing in my surrounding community, you know, I just don't know that the patient's getting the intended advantage, you know, from the CLEAR study. You know, so I think that's really significantly.
Yeah, I mean, I tend to think, and I tell this to patients and when I'm discussing with others, I do believe that there's something about the len-20. And I say, if you're worried that your patient won't be able to tolerate len-20, so then give a different regimen. But I also agree with what you were saying is that, you know, I don't know what the marginal benefit, if you could say there really is one, between len-pem and cabo-nivo. And if someone, you know, if I'm doing these community discussions and they say, we give a lot of cabo-nivo, or even we give a lot of axi-pembro, knowing that the hazard ratio are all leveling out right about the same place. If you don't have a ton of experience in a community setting and you're comfortable with one regimen, then just give it well.
Well, it's interesting. The three regimens took very different approaches to TKI dosing. Axi start in the middle, go up or down. Cabo was started kind of in the middle, right? Started notch down, and len was like, let's give as much as possible, right? And I don't know. I'm sure there are people who get cabo-nivo or axi-pembro who are underdosed for TKI. I'm sure of it.
Yeah.
It obviously didn't affect the survival advantage for either, but I guess conversely, there's a lot of patients who are overdosed at len-20. You know, so I think I said this last night at a meeting. I mean, after 20 years, we still have no idea how to give TKIs, right? We have no idea how to dose them. We have no idea how to titrate. Like, I've thought about this a lot, and we still have no idea, amazingly, 2 decades later, right? Because you do this, and I do that, and somebody else does that, and so it's a bit all over the map.